Today I'm discussing the results of the multi-center study of Ixazomib maintenance after allogeneic transplantation in high-risk multiple myeloma, BMT CTN 1302. So the study was specifically looking at allogeneic transplantation in high-risk myeloma, and this is based upon the prior study that was done by CTN, which is 0102, where the tandem autologous transplant was compared to tandem auto-allo from an HLA-matched sibling donor. In this prior study, they showed long-term improvement in PFS with high-risk myeloma, and we had emerging data at the time showing the combination of proteasome inhibitor to Fludarabine Melphalan conditioning was promising, and also some toxicity concerns of using immunomodulatory agent after allotransplant. So then we basically hypothesized that the combination of Bortezomib to Fludarabine Melphalan and using Ixazomib maintenance would improve the outcome. We conducted this study by looking at patients who had high-risk myeloma or standard-risk myeloma with prior progression, and took them to transplant with a conditioning regimen of Fludarabine Melphalan and Bortezomib. In about 2 to 3 months after transplant, we randomized them to either Ixazomib or placebo in a 1-to-1 fashion, and we plan to continue maintenance therapy for 12 cycles. We had some initial toxicity concerns, and the study was put on hold, and we modified the protocol by removing Bortezomib after transplant and continue the study, and we had 40 additional patients on the study. The study unfortunately was closed prematurely due to slow accrual, and in total we have 21 patients in Ixazomib arm and 22 in the placebo. And the median number of treatment completed in Ixazomib group was 12, and for placebo was 6. There were some patients who discontinued therapy due to toxicity or progression, but overall, more than half of patients in the Ixazomib arm was able to complete 12 cycles of therapy. And looking at progression-free survival and overall survival, the groups between the Ixazomib and placebo, there were no differences, suggesting there is no significant impact of maintenance. But also looking at the overall cohort of transplanted patients, the overall survival and progression-free survival was very promising. So the overall survival at 2 years was 82%, with a transplant-related mortality at 2 years was also 11.7%. And focusing on post-hold conditioning regimen, which was a Fludarabine Melphalan Bortezomib with no post-transplant Bortezomib, non-relapse mortality at 2 years was actually 8.7%, again suggesting the safety and feasibility of this transplant platform. So overall, I believe the allogeneic transplantation for high-risk multiple myeloma is feasible. However, due to many available options today, allogeneic transplantation may not be performed as a standard of care. However, it will be a question that we address in a well-designed clinical trial.